Thanks everyone for joining us today. My name is Josh Fox Fuller. Dr. Carter, if you can hit the next slide, please. So welcome to the lecture today. We're all pleased that you could be here for this week's lecture in Volume 3 of the Neuropsychology Didactic Series, which brings you lectures from experts in the field covering different topics each week. Next slide. The Neuropsychology series was created by trainees and early career neuropsychologists to provide free, high-quality didactic opportunities. Next slide, please. We would like to thank our sponsors for their financial support of the series. Next slide, please. And before we start, there are a few disclaimers for the series. So this training is not meant to replace formal education in neuropsychology, and the views of the speakers are entirely their own. Next slide, please. Questions today, or next slide, Dr. Carter, sorry. Questions today can be submitted via the Q&A box at the lower left of the screen, and the recording of today's lecture will be provided on our website later this week. Next slide, please. So now it's my pleasure to introduce Dr. Kirsten Carter for today's lecture on rehabilitation. Dr. Carter is a board-certified clinical neuropsychologist at an outpatient comprehensive rehabilitation program which has the mission to help individuals with acquired brain injury reintegrate into the community. She earned her Doctor of Philosophy in Clinical Psychology and completed her internship at the University of Texas's Southwestern Medical Center. She completed her postdoctoral neuropsychology fellowship at the University of Oklahoma Health Sciences Center. She presently treats individuals with acquired brain injury looking to increase their involvement in the community and completes neuropsychological evaluations with patients who have various neurological and neurodegenerative diseases. Her research interests include the ecological validity of neuropsychology measures, as well as the effect of social cognition and executive functioning difficulties on vocational outcomes. So Dr. Carter, thank you so much for joining today, and you can go ahead and take over.
All right, thank you so much for that introduction. Hi everyone, happy Monday. It is a pleasure to be here with all of you today. So when I was asked to give this presentation about neuropsychological rehabilitation, I was extremely excited because I feel like there is so much that can potentially be discussed. But the focus of this presentation will be on neuropsychological evaluation within the rehabilitation setting. So I have a few objectives that I hope that we can accomplish by the end of this presentation. And so by the end of this presentation, you'll be able to describe the International Classification of Functioning, Disability, and Health Interaction Model, or the ICF model for short. You'll be able to describe important considerations for neuropsychological evaluation with a rehabilitation focus. And you'll additionally be able to describe ways to individualize neuropsychological recommendations. Okay. So I'm pretty sure that all of us in this audience are familiar with Division 40 of the American Psychological Association, Clinical Neuropsychology. So clinical neuropsychology is a study of brain behavior relationships. So specifically, we study, assess, and treat emotional, cognitive, and behavioral changes that are mediated by the brain or changes to the brain. Another specialty within psychology is rehabilitation psychology. And this is another specialty that focuses on more of the study and the treatment and prevention of disability, as well as management of chronic medical health conditions. So rehabilitation neuropsychology is the intersection of these two specialties. It involves assessing and treating patients with brain injuries or other neurological conditions to help ultimately reduce disability and to improve function. So before we go into that further, I would like to discuss a little bit more about the concept of disability and specifically the ICF model. So the ICF model is a framework for organizing and documenting disability as well as functioning. So it was first introduced in 1980 by the World Health Organization, And the purpose of it was to provide a standard language that can be used by healthcare providers, insurers, researchers, as well as policymakers, lawmakers, when discussing disability and functioning. So when WHO goes on, the World Health Organization, when WHO goes on to describe what is functioning versus what is disability, these are generally working definitions that the organization provides. So think of functioning as an umbrella term that is used to describe body functions, body structures, as well as one's ability to participate in activities and different life tasks, or I guess more so life roles. And functioning denotes more of the positive aspects of the interactions between an individual with a health condition and the individual's interaction with their context or their environment. So disability is an umbrella term for impairment or limitation in activity and participation restrictions. And it covers the negative aspects of the interaction between the individual and their contextual environment. So some other factors that are accounted for in the ICF model include body functions, which is the physiological functioning of the body system. And this includes psychological function, as well as body structures, which are the anatomical body parts, organs, limbs, etc. So for example, an eyeball would be a body structure, and vision would be an example of a body function. Or in our case, the brain would be a body structure, and memory can be an example of a body function. Activity refers to the execution of a task or an action by an individual. Participation is a term that describes an individual's involvement in their life situation. And then environmental factors are the physical, social, and attitudinal environment in which people live and conduct their lives. And these can either be barriers or facilitators of a person's general functioning. Okay. So when the ICF model was first constructed in 1980, it looked something similar to this. So you have your medical condition on the top, and then the model demonstrates how changes in body function and structure can impact one's ability to participate in activity, which can impact their ability to participate in their life. Notice the progressions of the levels of functioning. So here you have the body structures and functions, which is discussing the physical realm. So this is talking about how a person's body functions, so how organs function, how our mental capabilities function, etc. And then you progress to activity, which is how a person or an individual functions as a person, as a whole, how all the body functions and structures come together to do a specific activity. And then participation is a further progression. It is how a person is able to function within a social context. So this was a working model in the 1980s. And what was found was that when the model was as is, there tended to be a focus on the medical condition itself, as well as the consequences of the medical condition, as opposed to other factors that could modify the medical diagnosis. Also, they found that this model was generally incomplete because individuals who had similar medical diagnoses may have different levels of functioning or different levels of participation in their life. On the other hand, people with different health conditions or different diseases may have similar levels of participation or similar ways that they approach activities. And the way the model is now, there's no other factors that can really account for these differences that were being observed. So approximately 20 years ago, in 2001, the ICF model was amended to incorporate environmental factors as well as personal factors. And as the model suggests, all aspects of the model have bidirectional relationships with each other. So for example, if someone had a spinal cord injury, a complete spinal cord injury that impacts mobility, It may make it difficult, for example, to access a non-ADA compliant building in the community, so an environmental factor. Additionally, environmental factors can also impact a health condition or a disease. If someone is living in abstract poverty, extremely poor, or living in a building that has lead paint, that can lead to changes in body structure and functions, which can also result in a health condition or disease. So the current ICF model, essentially, this just provides a framework for us to describe how biopsychosocial factors can impact one's function. So let's take a look at the ICF model in action. So here's a case study of a patient that I've treated. So the patient is a 60-year-old right-handed male who sustained an ischemic stroke in the M1 branch of the right middle cerebral artery. After earning his MBA, he opened his own finance company back in the 1980s. Essentially, the job duties are his finance company reimburses his clients for invoices and then collects the payment from those invoices. The patient had several major clients, and his basic work duties were reconciling invoices and then managing payroll for himself, his sole employee, as well as family members who also helped him with the company. He and his wife had been married for 23 years, 3 adult children. And then after the stroke, he expressed a desire to return to work. So using the ICF model as a way to conceptualize this patient, it may look something similar to this, assuming that the participation aspect or the patient acting in a social context is operating his family's finance company. So you have your medical condition, which is the ischemic stroke. You have your body structures and body functions. So the structures would be the brain and the right to middle cerebral artery territory. So right frontal lobe, parietal lobe, temporal lobe for this gentleman. You have your body functions. He had a visual field cut. He had left neglect, executive function, amongst other cognitive changes. So an activity or something that he would do as a whole person would be reviewing account records. That's a specific activity that he could do. Whereas operating his family's finance company and running this company that he owns is an example of life participation. And then, of course, there are other environmental factors that contribute to the person's ability to function within the context. So he resides in a really large metroplex, has access to healthcare, works in an environment with very supportive coworkers, family mostly. And then there are other personal factors. So being married, adult children, also personal factors like having a long-standing habit of reconciling books. So a few things to keep in mind about the ICF model. It does not classify people. So this is not a way to classify people. It is just a way, it's just a tool to think about disability and functioning and to consider all of the factors that contribute to it. The ICF model takes into account both biological functioning, psychological functioning, as well as environmental factors that contribute to disability or being able to fully function within one's environment. Another thing to keep in mind is that disability isn't the same for everyone. It can be intermittent, it can be permanent, it can be continuous, it can be temporary. It just really depends on the individual. And the most important thing to take home is that having a medical diagnosis is not synonymous with having a disability. So it is possible to have a medical condition and not be disabled. Okay, so let's bring it to neuropsychology. The reason why I wanted to focus on neuropsychological evaluations for this talk is just because it's something that is done in most settings for neuropsychology. And neuropsychology evaluations are the cornerstone for what we do. Usually it's a standalone service, or it is the starting point for what's to come, whether that's recommendations or interventions that you will do as a provider yourself, or that other providers may do based on the recommendations that you make. So here is a list of common referral questions in a rehabilitation setting. So you may have a patient referred to you in a rehabilitation setting for treatment planning to help establish goals for community reentry, whether that's returning to work, returning to school, volunteering, or even just increasing one's independence in their home, or increasing their independence in the community, being able to go to the grocery store unaccompanied or with as little supervision as possible, things like that. You may get patient referrals for goals to this end. A lot of times patients are also referred to neuropsychologists in a rehabilitation setting to help identify and ultimately address barriers for treatment or for progress with goals. So this can include pain, mood, motivation, neurobehavioral symptoms. It just really depends on the patient, but it can entail a lot of different things. A neuropsychological evaluation in the rehab setting is also beneficial for measuring one's progress across their recovery trajectory so that we can see how they're doing, and also to help determine the need for additional services. So in most rehabilitation settings, you are usually working with a team of some sort. And so usually there is a referral source and there may be an interdisciplinary team with whom you're working. So here are some considerations whenever you are generating a neuropsychological report in these different settings. So with regard to the referral source, meaning the physician who refers the patient to you, and this can be a PM&R physician or a neurologist, one important thing to do is to respond to the referral question and to ultimately to clarify the referral question and to respond to the referral question. So it's not uncommon to get a referral question that asks you to clarify cognitive strengths and weaknesses, only to find out later that the physician wants to know if you think the patient has capacity to make medical decisions. And so those are two very different evaluations. And so it's really important to know why the doctor wants to refer the patient to you and what they want to get out of the neuropsychological evaluation. And this goes back to the ICF model as well. So cognitive strengths and weaknesses is talking about functioning on more of the body structure and body function level, but to what end? In what context is a patient going to be using these cognitive abilities? And asking more questions about that can help answer some of the questions that providers may pose in rehabilitation settings. So you may also have a patient referred to you just to inform treatment planning. A lot of times, PM&R physicians or neurologists want a patient to come to you so that you can treat them either with cognitive rehabilitation or psychotherapy regarding their injury. So another consideration is communication with the rehabilitation team. A lot of times the rehabilitation team may turn to the neuropsychologist or the neuropsychology report to obtain information regarding the emotional, cognitive, or behavioral status of a patient who has sustained an injury. Oftentimes rehabilitation teams may look to the neuropsychologist to answer questions about why a patient may have a certain presentation and what's driving that, whether it's emotional or whether it's cognitive, and potential answers to address it if it is a barrier to function. Another consideration when working with the rehabilitation team, whenever you are writing a report, make it as succinct and easy to read as possible, just because it's a lot of times, I know myself, I'm guilty of using a lot of jargon that may not be easily or readily understood by people who are not within the psychology field. But it's important to make a product, the report, something that is accessible to everyone and that other healthcare providers can read and implement the recommendations that we have. So another difference between a rehabilitation setting and other settings from neuropsychology, from what I noticed, is that in rehabilitation settings, we tend to focus more on function. function, activities, and participation. So here, I'm going to demonstrate an example of what I mean by that and reflecting that in report writing. So here is an example of a clinical impressions that is not unlike other clinical impressions that I've made in other settings. And so this is for the same gentleman with the ICF model. And so the clinical impressions read, you know, the neuropsychological profile is significant for attention, visual, spatial, visual memory deficits, difficulty with mental set shifting, abstraction, inhibition, problem solving, reduced awareness, no significant emotional symptoms, altogether consistent with his history of right MCA territory infarct. So the way that this clinical impressions is written is more of a focus on differential diagnosis and the cognitive profile itself. So oftentimes, not all the time, but oftentimes in rehabilitation settings, we are already familiar with where the injury is or what has happened. And of course, with inventions such as neuroimaging, oftentimes we don't have to use the cognitive profile necessarily to identify exactly where the lesion is in the brain. So having a differential diagnosis, although correct, may not always be as helpful in this particular setting. So that's not to say that we will never use differential diagnosis in this setting. In fact, differential diagnosis is actually a common referral question. For example, a patient with poor awareness, like this gentleman, in their cognitive difficulties, people may wonder where that presentation comes from. So for example, is a patient showing poor awareness because they don't know about their injury and they haven't learned what's happened to them? Are they showing poor awareness because it's a result of the brain injury itself and it's anosognosia and they have a hard time perceiving differences in their environment that will give them the feedback that they're not performing as well as they think they are? Or, you know, is it an adjustment difficulty? And the way that they're coping is through the use of denial, and it's more of an adjustment difficulty as opposed to a brain injury. So I'm saying that to say that differential diagnosis is commonly used in a rehabilitation setting, but the focus in the report is usually more functional. So here's an example of a more functional conceptualization of the same patient. I know that this is a busy slide and has a lot of words, so I'll just read a few key points. So going back to the ICF model, where we focus on the function, the activity, the participation. So following stroke, he has mental inflexibility and impulsivity that will impact his ability to carry out work duties. He has difficulty detaching himself from his immediate environment to see the larger picture. That's more of the functions. And then you have the environmental and personal factors. So he owns his own company. He's ran it for decades. He has family support within the company. Also a personal factor. He has this longstanding habit of reconciling books. And so this longstanding habit may serve him after this injury. Another environmental factor, you know, he's worked in finance where there are laws that govern the way he has to do certain things. And by having to do certain things habitually in the same way for many years on end, being in this particular environment may impact his functioning after his particular stroke. So a few other considerations that I just wanted to make sure that I cover. As always, we want to make sure that our reports have patient-friendly language because patients love to read the report. And a lot of times whenever, you know, we are giving them information about things that are important to them, such as whether they can return to work or return to school, they may hang on the words that we tell them. So it's really important to put it in a way that is understandable and not communicate information that may diminish hope. So I also want to comment quickly on predictive validity as well as ecological validity. So with regard to predictive validity, it's really important in our reports not to make sweeping statements about the future based on the current neuropsychological assessment that we have. So people can have different trajectories from recovery. And so it's important not to make sweeping generalizations such as a patient will not be able to return to work, or based on this level of impairment, these particular activities will not be able to be done in the future. So with regard to neuropsychological evaluations in the rehab setting, I tend to focus on the here and now. So maybe the patient is not appropriate to drive at this moment because he has left neglect. However, we can continue to measure progress in the next few months. A note about ecological validity. So it's also important to know about the benefits as well as the limitations of our neuropsychological evaluations. And ecological validity is a concept we need to keep in mind. So in a lot of ways, having someone and testing someone in a very quiet testing room where we try to make them as comfortable as possible is not like the real world. So if a patient does really well in a very controlled environment, such as a neuropsychological evaluation, that doesn't necessarily mean that they won't have difficulty in an environment that may be less structured or have more noise, or has the demand of them also having to walk or run or look at various visual stimuli within their visual field. Also, it's important to note that testing individuals in a quiet and controlled environment also doesn't have those environmental factors that can be beneficial to a patient, that can provide support in ways that we may not expect. I'll give a quick example of this. So I had the fortune of being able to work with a gentleman. I worked with him in inpatient, and then as I transitioned to an outpatient community reintegration program, he was also referred to the outpatient program at the same time. I had the benefit of being able to see his cognitive scores from the acute setting all the way to a more chronic stage. So from a cognitive perspective, on paper and pencil testing, his performance didn't improve all that much. However, from a functional perspective, he showed leaps and bounds. So he was actually a equipment sales manager for an oil and gas company, very gregarious guy. People loved him. Everyone knew his name. And he wanted to return to that work. However, he had sustained an anoxic injury secondary to cardiac arrest. And because of his cognitive difficulties, he was not able to return to that position. However, during the COVID-19 pandemic and sheltering in place, he actually started a sign business with his family and had a lot of support from spouse and the community, and was able to sell those signs that you put in your yard that say like happy birthday and those sorts of things. And so even though he still has the same cognitive difficulty that he had a few months ago, from a functioning perspective, he's doing really, really well. So I'm saying all that to say that it's important to know that the neuropsychological test scores are not the end all be all. It's one data piece of information to consider with the other factors, environmental factors, contextual factors, personal factors, et cetera, to look at a person's function. All right, so I work in a rehabilitation setting, and I generally work with individuals who have acquired brain injuries or other neurological disorders like Parkinson's disease or multiple sclerosis. However, I did want to briefly comment on neurodegenerative diseases in the rehabilitation focus. So individuals who have sustained a brain injury, the focus for rehabilitation is improving function. So for neurodegenerative diseases, the focus is more on prevention and then reducing morbidity, or trying to allow the individual to live as fully as they can before the disease takes over, so to speak. So there is a lot of research out there about rehabilitation for mild cognitive impairment or dementia populations. In 2020, last year, there was this great article published about modifiable factors that can help prevent up to 40% of all dementias. And so these are just important things to keep in mind when we're talking about rehabilitation in a neurodegenerative population. So prevention is key, and maintaining functioning for as long as possible is also something that we want to strive for. And so here is just a list of those 12 modifiable factors that can prevent up to 40% of dementias. And so notice how a lot of them are, personal factors like education. You have some body structures, a hearing loss, not getting a traumatic brain injury, alcohol, obesity, smoking, depression, social isolation, physical inactivity, air pollution, got an environmental factor there, diabetes. All right, so after we complete the neuropsychological evaluation with the rehabilitation focus, then it's time to write our recommendations. So this slide simply serves as a list of things to consider whenever you're writing your recommendations. Can you speak on diagnosis and prognosis? Can you comment on that? Is there a need for reassessment? And so in order to not seem as if neuropsychologists are taking advantage of being able to do neuropsychological assessments or referring patients to ourselves repeatedly, is often necessary to identify a reason for reassessment. Is the person at a crossroads in their lives where they want to undertake a new goal? For example, they have been receiving disability benefits for a while, and now they want to apply for a job. So is there a functional change that needs to be assessed? So another recommendation that needs to be included is whether or not the person will need some sort of intervention or rehabilitation service. So psychotherapy to address mood or awareness difficulties, or rehabilitation, like cognitive rehabilitation or services of that nature. Do we need to comment on safety and supervision? Is the person able to operate independently in the community? If not, how much supervision will they need? And what are the steps to gradually reduce the supervision over time if that is appropriate for this patient? We also need to make sure that we address vocation as well as community participation. So it's not enough to improve the areas that the person is having difficulty, but improve it to what end? For what purpose? What is the person doing in the community that is meaningful and fulfilling to them? What environmental modifications, if any, does the patient need? Do they need accommodations at work? Does there need to be an environmental modification in the home where family members think that the patient may be lazy or is a personal failing when it's really a symptom of the brain injury? Maybe the recommendation is have education to the family. Also, other recommendation considerations that we need to make sure that we think about are non-rehabilitation services and other resources. How's the person's sleep? Is their pain being managed, etc.? So with regard to recommendations, to be a little bit more specific about what we should consider, and here we are, it's important to be as specific as possible whenever we are giving recommendations. So if we go back and we conceptualize the ICF model, it's easy to see how everyone can be highly individualized just based on not only the medical condition, but their body function and how it was affected by the medical condition, the activities and participation that they're interested in, as well as the different environmental factors and personal factors that contribute to the overall picture of functioning. So having all of that knowledge, we need to use it to be as helpful to the patient as possible. So here's an example. So I've been guilty of doing this, although I try not to, writing recommendations for a report. See, there's a top recommendation, that says, the patient would benefit from cognitive rehabilitation to address reduced awareness, as well as attention, visual, spatial, and executive function difficulties. So that's a correct recommendation. And it does apply to the clinical impressions for the patient that we were discussing earlier. However, we can be more specific and individualize the recommendation more by using all of the information that we have. So here are some more specific examples of writing the same recommendation as the one above. So giving some education about why the recommendation may be important and how it can affect treatment. So awareness building is important for interventions to be effective because a patient may not be engaged if they're not aware of their difficulties, and this is how we build awareness. This is an evidence-based treatment to address the attention difficulties. Here is an evidence-based visual scanning strategy that can help with visual field difficulties that the patient is having, as well as to help with the left neglect. Here are other strategies, goal management strategies that can be used for helping with the executive function difficulty. All right. Here's just another example. The patient would benefit from receiving accommodations to facilitate work reentry. It's more helpful to the patient if we can be more specific about the types of accommodations that the patient would benefit from, and individualize it not only to the patient themselves, but also to the work environment in which they are returning. Whenever we are writing recommendations for neuropsychological evaluations, it's also important to consider contextual factors. And so what I mean by that is consider environmental factors that may be affecting the patient. So I know I've had the experience where I've seen a patient and I know that they would be perfect for a specific program or a specific treatment that is not available to that patient because they live too far away, or they don't have the transportation resources, or they don't have the funds to be able to afford that type of treatment. So although I do think that we should recommend the gold standard of treatment for the patient, we should also work to try to develop a treatment plan that is accessible to the patient in that moment based on their current contextual factors. Otherwise, we're almost giving another barrier for treatment as opposed to giving another way for the patient to improve their function. And then lastly, it's really important to make recommendations functional. By functional, I mean a recommendation that can be incorporated into their daily life and helps lead them stepwise into an activity that is important to them, or an involvement, a life participation involvement that is important to them. So I'll go ahead and give my luminosity example. Luminosity, a lot of my patients ask about luminosity, and I always tell them, the general, if you enjoy it, that's fine. However, working on luminosity is only going to make you really, really good at luminosity. Research does not suggest that working on luminosity, if your memory scores improve in luminosity, that results in memory improvement in a functional setting or in the real world. So similarly, there is a concept of specificity, whereas if we participate in an activity, we do tend to improve in that specific activity that we are doing. So I'm saying that to say that if a person is interested in returning to work in finance and has attention difficulties, it would help the patient to incorporate activities that mimic the types of duties that they would do at their job to help remediate the attention difficulty, but also to help them improve in that specific area for a goal that is important to them. So that's what I mean when I say make recommendations functional. Think about the environment and the role that the patient wants to have and make your interventions and remediations specific to that environment and to help them with those skills. So not only will that help the patient improve in those specific areas, but also because that's so salient for them and it's part of their goal, their motivation to engage in it will likely be higher than doing other activities that are not related to their personal goal, or doing things such as completing worksheets or things of that nature. All right, so I went through those slides a lot quicker than I had anticipated, but if you have any questions or comments, I would love to hear them.
Great. That's all right, Dr. Carter. I think the nice thing is we have plenty of time now for questions and answers. So we have a few questions from the audience. First of all, I want to say thank you so much for your talk today. I think, you know, all of us as a trainee, I don't know if I speak for all trainees, but we certainly, and probably at every career stage, we can use reminders about tailoring our recommendations to patients and individuals we work with. So I like these recommendations, the recommendations, examples you provided, and how you integrated them with the rehabilitation framework from the beginning. I think that's really important and a big takeaway for all of us. So one of the first questions we have is asking, how much of your practice in neuropsychology or now do you find yourself conducting neuropsychological assessments with a rehab focus versus doing intervention focused care like CBT or cognitive rehabilitation?
So currently I'm actually in between employment opportunities. However, in a rehabilitation setting, I would say that it varies depending on where you are, and your role as a neuropsychologist may also vary. There are some settings that would prefer for you to do more intervention than assessment. And then there are other settings where neuropsychologists are more of a consultant role, where we do assessment and then we come in and help inform the team about how to carry out recommendations or implement certain treatments. With that being said, at my previous job, I was doing about 3 to 4 brief assessments per week, and a large majority was intervention.
Great. Okay, that's helpful, I think, for us to know. It's nice to see that we can have that split. On that topic, what was your pathway, or what are some common pathways to becoming more rehabilitation focused in neuropsychological training or psychological training in general?
So my recommendation would be to seek out training opportunities where there is a rehabilitation focus. So internship opportunities, as well as postdoc fellowships that incorporate neuropsychology and rehabilitation. I will also say that that was not my pathway. So a little bit about me. My graduate training as well as my fellowship experience was mostly in outpatient clinics, where I did a lot of assessments for neurodegenerative populations. I kind of stumbled into rehabilitation and found that I really loved it. And so once I was here, of course, it's a lot of self-studying and making sure that you continue getting the continuing education and becoming involved with Division 22 and other professional organizations so that you can continue your learning. So that's what I would recommend. If your training has not given you the opportunity to have many rehabilitation opportunities, there's other ways to further your study to hopefully use in the future.
Great. Another question from our audience is asking about going back to that slide that you had about the modifiable risk factors for dementia. I don't know if you want to advance back. They said the slide was a little small, but they were curious about kind of the groups of factors, so they couldn't quite see it all. So maybe if you want to take a second to walk through that in a little more detail.
Sure, absolutely. So the risk factors, there's 12, is less education in early life, So in the Lancet article about dementia prevention, one of the recommendations was to provide primary and secondary education to all children. Hearing loss, believe it or not, is a contributor to dementia. And so the recommendation is to check hearing and to make sure that it is treated with hearing aids. I believe the thought behind that is that the hearing loss leads to atrophy in the brain, meaning, if you don't use it, you can potentially lose it. So that was found to be a contributing factor. Having a history of traumatic brain injury is another modifiable factor. So protecting your brain can help reduce your chance of dementia. The usual suspects, so hypertension, of course, excessive use of alcohol, more than 21 units per week, obesity, smoking, untreated depression was found to be a modifiable risk factor for dementia, social isolation, being inactive, physically inactive, air pollution, as well as unmanaged diabetes.
Great. That's really helpful to walk through it. It's a great slide, and that looks like a really good article that I'm going to add to my list to read. We just got a question a second ago. They were curious. I'm not sure have you worked at all in any inpatient settings for neuropsychological assessment? Okay, yeah, they were curious about sort of the setting of the inpatient setting and what are some common referral questions that you received there. And when you think about the inpatient setting and the functional status of those patients, how do you work on tailoring the summaries and impressions and recommendation sections in that sort of clinical setting?
Absolutely. So that's actually a really great question. In an acute setting, it is hard to have a full clinical impressions as the one that I provided. So in my experience, whenever I work in an inpatient setting, I found that the referral sources usually were interested in knowing how the patient was doing from an emotional, cognitive, and a neurobehavioral status to reach the ultimate goal, or the community goal, is a safe discharge and to transition to an environment in which they have the least amount of supervision that is appropriate for that patient. So if you go back to the ICF model and you think of the participation or the activity or the community reintegration goal, the way I kind of conceptualize it is we're looking for a safe discharge and we're looking for the patient to go to a place where they have the least restriction as possible. So some common referral questions that I get can include, of course, assessing cognitive strengths and weaknesses, which that can always mean anything because that can transition into, does this patient have the capacity to agree to medical decisions? Or does this patient have the capacity to live at home alone? Sometimes they want my take on what settings after discharge would be beneficial to the patient, whether an outpatient community reintegration program would be helpful, or whether the patient would need more structure, like in an inpatient setting, or more of a unit where you go and you live there while you're receiving rehabilitation. Some other things to keep in mind that they don't necessarily ask for, but with our expertise as neuropsychologists, we can just offer. A lot of times, especially with specific injuries or diagnoses, we, because of our training, know what to expect from the profile, or we might be able to kind of guess what could potentially happen based on the injury itself or the brain structures that are provided. So a lot of times it's just providing your expertise about those things. So a common example might be someone who sustained a traumatic brain injury and they are experiencing a post-traumatic confusional state. And so they're disoriented and have sleep-wake disturbances. And so people may assess them, and this isn't very common for people who work with brain injury commonly, but it can happen. They might think the patient is severely impaired and, make recommendations on the basis that their impairment will remain severe, whereas if they just pass this post-traumatic confusional state, you might see a bump of improvement. That might not be representative of how the patient might look in a few days. And so I'm asking the team to consider those factors. Or if you have a patient who has sustained an injury that affects the frontal lobes and they're sedated most of the time, and but now they're coming off sedation, giving the team a heads up that, there's a possibility that we may see neurobehavioral symptoms. So those are some of the referral questions, but also as a neuropsychologist, you offer information that you see happening that the treatment team may or may not think to ask you.
Right, that's really helpful to hear all of that. It sounds like it's a very fast-paced environment with the inpatient setting and a lot of different trajectories, but that's great to hear. I'm going to ask, I think, two more questions. One, that's from our own Alexander Tan, UT Southwestern alumnus as well.
Yeah.
And then I'll do a kind of a question to wrap us up. So Dr. Tan's asking about kind of your experiences more broadly working in the multidisciplinary setting that is the rehabilitation team, because I'm sure there are obviously many pros, but there also might be challenges or barriers that you might have faced. So maybe if you want to speak somewhat to your general experience working in rehab settings.
Absolutely. So I definitely think that there are definitely pros as well as barriers. I'll start with the barriers and then I'll discuss the pros. So when working with the rehabilitation team, it's one thing that I didn't realize before coming into the environment, or I guess I wasn't cognizant of, is that different disciplines might have a different set of ethics or a different way of doing things. And oftentimes, if you're the only psychologist or neuropsychologist on the team, it's up to you to stand your ground about the ethical expectations of a psychologist with regard to confidentiality, to protecting tests and protecting, our testing materials and things of that nature. Of informing the team that you might not necessarily be able to tell them everything that the patient tells you because they don't need to know those things. And so that was a challenge that I particularly had to get used to. Some of the benefits of working with a multidisciplinary team is that I feel like I've learned a lot. It has also been really helpful working with other disciplines and seeing how they conceptualize a certain presentation that I see. And I found that to be really rewarding as well. The way I kind of see it is working with the rehabilitation team, I kind of see it as an extensive neuropsychological evaluation. So you get the information from the team and you integrate it all together to come up with this conceptualization of how the patient is functioning. And being able to have all of those areas of information contribute to your conceptualization of the patient has been really, really helpful, I will say.
That's great. So for the wrap-up question, I wanted to ask, you kind of hinted that too, like the luminosity thing, that the cognitive rehabilitation literature is very mixed in terms of transference effects of trainings to cognitive trainings to other, ecologically valid experiences in the daily life. So when you think about sort of the current standing of the research and the clinical work in cognitive rehabilitation and rehabilitation more generally, what are some future directions or areas that you think the field needs to address as we move forward?
That's a really good question. One thing that I've been thinking about, just because of everything that's going on currently with the global pandemic, is I notice that there is a more reliance on computer use and communicating through social media. And look at this conference. This conference is even done virtually. I do wonder if we're going to shift to more virtual modalities going forward. And I think that neuropsychological rehabilitation needs to keep up with that. I'm not exactly sure how that will be done, but I think it's something that needs to be addressed. There's even research to suggest that a lot of, like most people, whenever we meet people or meet new friends, at least for the younger generation, a lot of that is done online. And so whenever I think about individuals who have sustained brain injuries, I think that this is a direction that we need to help, because that may not be as easy to navigate for many reasons for this particular population.
Great. Yeah, I think that, I mean, the role of technology, I think, will definitely play a role, both in education, as you mentioned, and just more broadly. It'll be interesting to see how, too, it can impact like inpatient populations as well. So I think we're just a couple minutes before the end of the hour, so we can go ahead and wrap up here. Do you mind advancing to the final slide just so we can have that? While you're doing that, I just want to say thank you so much, Dr. Carter, on behalf, or just one more slide. Yeah, thank you so much, Dr. Carter, for coming here today to be a part of our didactic series and talking to all of us about rehabilitation psychology, and to our audience as well for all of their questions that they asked. There's so many questions in the chat about that they've provided. Just one more slide, sorry, back to the left side. And oh, other way, sorry. It's okay. It's kind of like
Sorry.
it's okay, no worries. One more, just back to the other one about the next week's lecture. Sorry. I think there we go. So just to be sure, everybody, to tune in next week for our lectures, which you'll get information about in your email by Dr. Arce Renteria about deconstructing bilingualism and its sociocultural determinants on cognitive aging. And thanks again, Dr. Carter, for coming in. And for anyone who wants to watch the recording, it should be uploaded within the week or so.